Today's guest is Dr. Joshua Lee, who is a Chief Clinical Advisor who specializes in medication-assisted treatment of alcohol and opioid use disorders. And Dr. Lee conducts clinical trials and treats patients struggling with addiction as a primary care physician. As a professor at NYU at the Grossman School of Medicine, he leads the Addiction Medicine Fellowship and conducts research focused on justice and community outcomes. And today we're going to be exploring addiction treatment. We're going to be talking about Naltrexone and if he encourages the use of that or under what circumstances he would encourage that. And we're just going to have a great conversation about evidence-based treatment. Dr. Lee, welcome to the show.
Thank you. Great to be here.
Would you just tell our listener a little bit about what you do and who you do that for as it relates specifically to alcohol use disorders?
Yep. I trained as a primary care doctor in internal medicine as opposed to like family medicine. So I'm a GP, and then I later would specialize before it was an actual board certified specialty in addiction medicine. And now we have a fellowship in addiction medicine. It's one of the newest specialties in American board certified specialty care. And that is alongside addiction psychiatry, which has existed for longer in the States. And so those are now kind of like two addiction specialty credentials you can get as a GP, as a psychiatrist, as an emergency room physician, as a pediatrician. So that's been one focus, is doing more kind of in general medicine and from a primary care perspective for addiction in primary care settings. A lot of addiction treatment obviously is, we think of rehab and 28-day inpatient and maybe long-term or other kind of residential care. And then a lot of fairly intensive outpatient work. And then of course, like 12-step peer support, more anonymous, confidential, community-based resources. Not so much, hey, I just go see my doctor, at the neighborhood health clinic, and that's where I'm getting treatment for alcohol or smoking cessation or opiate use disorder. So over my career, we've been trying to, really kind of blend in evidence-based principles of addiction and substance use treatment, prevention, and kind of medical and behavioral problems related to those disorders in primary care. And that, of course, is dovetailed with the opiate epidemic in the United States. So my career, I graduated med school in 1999. So my whole kind of career over the last 20 plus years has been largely thinking about reducing overdoses and dealing with the worsening overdose epidemic. And then in primary care, that became more and more practical because we had medications like extended release naltrexone, but first and foremost, buprenorphine products. That's Suboxone, Sublocade, other branded products that are now largely generic in terms of the daily oral stuff. And so a lot of my career has been that kind of responding to opiate use disorders, principally heroin and now fentanyl problems, with outpatient medications like buprenorphine. And then with alcohol, it's a lot of the same. It's like, hey, I'm in primary care. I can see you every couple of weeks, or maybe you're stable and we can check in every few months, but there's a medication that can help you, or that medication was okay, but you had a side effect, or you want to switch and let's try the second medication, or we can do these two kind of in combination. I also hope you explore AA or 12-step or individual therapy or any kind of other specialty help you want to get for an alcohol use disorder, and try and prescribe more medications than we do currently for a common treatable disorder. And so the larger thesis is, hey, we can do a lot for addiction you probably didn't know, and it can be kind of simple, fairly effective, and pretty accessible through something like a primary care visit. We can apply that to both alcohol, tobacco, and opiate use disorders.
Got it. Thank you, Dr. Lee. So as it relates to alcohol, I'd love to have the focus on alcohol specifically for this conversation. Yeah. If someone presents themselves into your office as a general practitioner, someone, and they say, I'm really struggling with alcohol, at what point do you say, okay, I'm going to prescribe you some medication versus say encouraging them to go to some peer support groups such as AA or elsewhere? Like at what point do you say, okay, I'm going to prescribe medication here versus okay, I'm not going to prescribe medication here?
Yeah, I want to bring it into the conversation right away, along with all those other resources, and kind of present like a menu of treatments. So we have this, we have that, we have this, we have that, and depending on the person and their preferences, just explore what they're motivated, capable, what's accessible to them, what they have time for. Often people have, often it's not the first time they're having that talk, and they've done this or that, and they have pretty strong opinions as far as what they want to do next. So I try and work with that. We don't just blanketly say, you, medical problem, now, medicine, take, come back, no argument, no discussion. I can't tell patients what to do. So I want to have a conversation and kind of develop a plan that is centered on their needs and strengths and their motivation. But I do want to offer medications early on, if not the first time we ever have that conversation, when we're really talking about making lasting behavior change and strategies that can be effective early, middle, late, kind of in the recovery process. I definitely want to address the use of medications. And some people that's going to click. Some people they have not heard of it, or they've heard a little bit and they're curious. It's not going to be for everyone, but there are plenty of patients that are like, oh, great, there's a pill I can take for this medical problem. They're used to that, especially if they're already, customers. Like, I know you're my patient, or you came to my hospital or called me on the phone for a televisit, kind of expecting, doctor type care. And I am, very much situated in kind of like mainstream health center, or through a company, or that I work with kind of an online prescription application. So what I'm, heavily kind of situated and invested in is like, what people would expect from me is like, I ordered a bunch of tests and prescribed a bunch of medications, like pretty standard, doctor stuff. So in that sense, it's not that shocking or surprising or unexpected for patients if we are talking about medications for alcohol, even if they didn't know about it before.
Naltrexone seems to be the most known prescription drug for what exactly? Could you just tell our listener who's unfamiliar with that drug and that medication, what does it do and who's it for?
Yeah, Naltrexone was developed kind of in the 60s and 70s, and then finally kind of in retail medicine by the 80s for alcohol use disorder and opiate use disorder. And why would it work for both those problems? Naltrexone is very much like an opiate. And in fact, the lore is they were looking for a kind of non-addicting opiate that would help with pain treatment. And they found this molecule, naltrexone. It turns out it fits really tightly and for some length of time at the opiate receptor in our brain, in particular the mu opiate receptor. And that is where a lot of activity is for opiates. So like codeine, morphine, heroin, they all work at the mu opiate receptor, which has a lot of kind of concentration in our midbrain and frontal cortex, where we kind of experience pleasure and then start to learn to kind of repeat that behavior. So it very much is kind of right in the pathway of what becomes for many people an opiate problem, where they need to keep kind of doing opiates to keep getting pleasure. And then because they get physically dependent on opiates and will get sick if they don't have them. What naltrexone can do is totally block that receptor, in the sense that this is a molecule that goes into our brain to that other molecule, which is the opiate receptor, kind of fits in there, but then it's an antagonist. It doesn't do anything. It itself is not an opiate. It's not a controlled substance. You cannot get high, euphoric, sedated, constipated on naltrexone as opposed to other opiates. So it's what we call in pharmacology an antagonist. It's going to a place where other medicines and stuff works, but it's doing the kind of opposite, or blocking the effects that are normally seen with agonist or kind of proactive agents at that same receptor. Now, why would that help with alcohol? I just told you a whole story about opiates. It turns out some of us drink for opiate-like pleasures. Alcohol has some opiate-like effects. It can help us kind of with feeling no pain if I'm in pain, feeling less anxious if I'm already kind of a little nervous, anxious, or irritable. The whole kind of I get euphoric and buzzed and kind of happy, the stuff I like about drinking, especially early on in a drinking episode. All that can be mediated by the opiate system, not necessarily for all of us, but for a lot of us. And so if you block the kind of alcohol stimulating your opiate system, you can still drink and get inebriated and intoxicated and a lot of other effects that alcohol has on the brain, kind of all over the brain. But if you're stopping the opiate-like effects, it may not be as fun, it may not be as tasty, it may not be as rewarding in the kind of subconscious and kind of conscious level. You may not think about it as much in terms of cutting down on cravings when you are kind of early in recovery and just trying not to drink. But it's 5 o'clock. I just finished the softball game with my buddies. I always have beers, this time of day, this day of the week. And it just helps you kind of not listen to that or not have that kind of message pop up on your internal, kind of like dashboard. So naltrexone for alcohol, for some patients, not all, it's not guaranteed. You have to kind of try it to see if it might have these effects on you. Can really kind of have people give statements like, I just don't think about it as much, or I don't really look forward to it as much. I don't like the taste of alcohol like I used to. And then net, you're hoping to get somebody on naltrexone on a daily basis, once a day, sometimes in a twice a day dosing, but usually once a day at the right dose. And they just drink less. They come back and tell you a month later, they have more days where they didn't drink, or they were able to quit once and for all for good. They haven't drank at all, or I'm still drinking. I'm kind of ambivalent if I'm going to stop drinking altogether, but I have more control over it. And I'm not doing as much heavy drinking. So after the softball game with my buddies, I had one beer, and then I had to go, and then I had a soda, and that was it. And instead of like sitting there and having the 7 beers you used to on naltrexone, I might not want to use as much, or I just am able to prioritize not using and different healthier choices. So, and it can complement any other behavior change or work people are doing with therapy, with AA, with groups, with online smart recovery, whatever other kind of resources. They don't really conflict with being on naltrexone. The only contraindication in naltrexone is being on opiates, because it's an opiate blocker. So if you are on chronic pain opiates, or I'm already in treatment for an opiate use disorder, I'm on methadone or Suboxone, and I have a drinking problem and want to get treated for that now, naltrexone will not fit. But for most people who don't have an opiate use disorder, are not on opiates, or not physically dependent on opiates, they can start naltrexone right away. There's a couple other conversations we want to have around side effects. If people have severe liver disease, we monitor that more closely than in people without any history of alcohol-related liver disease. But for most people, it's going to be safe and pretty accessible to try for a couple of weeks, try it for a couple of months. And again, there's no guarantees. It probably works in more people than it doesn't work. It does beat placebo in trials when you do more kind of rigorously designed randomized controlled trials. We think the number needed to treat is fairly low and acceptable, meaning the number I have to write a prescription to so that I get one person kind of giving me a total success story. That number is around 5 to 10, which is similar to other stuff we do in primary care in terms of prevention and treatment of other chronic disorders. But I do have to treat 5 to 10 people to get that one person who's like, miracle cure, that worked, doc, that was awesome. And that's a little bit better of a rate than I get with placebo or a sugar pill, but it's not like it works in everybody, or that everybody wants to take it for a long-term kind of process that of course can have a lot of ups and downs. And then the goal is then to kind of just use it to connect with the patient and have something you're both working on. And then, of course, our other perspective is come back and see me over the rest of your life. Like, let's keep working on what can be a chronic problem that can kind of come and go. And some days you're doing well with it, some days you're not. So kind of keeping people grounded and realistic about how hard it can be. And then also like how you need to kind of keep watering the plant, over the weeks and months, and it doesn't just happen all of a sudden, you're done and you never have to think about it again.
May I ask for you to elaborate on potential side effects for someone who maybe doesn't have a liver disease or any kind of pre-existing challenges, someone knows they drink too much. They've been trying to stop for a considerable time. They're unable. It's causing marital stress. Their blood pressure is increasing. They're not sleeping great, right? These are all behavioral things. But let's just say someone who's not, maybe I would submit, chemically addicted to alcohol. Maybe they've just got behavioral challenges and they're finding it challenging. Yeah. And they don't have pre-existing health conditions. What are the side effects of taking naltrexone?
I like that case too, because most people with the drinking problem can stop on their own. So they don't have like the physical dependence where they're going to go into a moderate to severe alcohol withdrawal syndrome. And that's something that we often forget, is that most people, even if you're drinking a lot per day, you can stop and you don't need to like check yourself into a clinic to start that process. And then say you and I don't have other medical problems, but we're dealing with heavy alcohol use and we want to try naltrexone. The most likely thing we would find is if we took a full dose right away, some tummy trouble, kind of like new antibiotics can upset your stomach. That's very common, especially if you start right away on a full dose of naltrexone. Usually it does not produce actual vomiting, but you can just feel kind of queasy, fluey, nauseous, and loss of appetite. And then we try and abate that by just starting at a slower, lower dose. And over the course of 1 week, say, going from like a quarter of a pill to a full 50 milligram dose. And then this kind of fluey, icky feeling is more common when people start naltrexone than versus like placebo. And that can also be experienced as kind of headachy and then overall kind of a flu-like feeling over the course of a day or two when you start the medication. Again, we try and minimize and prevent that by having people start on a lower than average dose and then ramp up over about a week just to make sure they're not having those problems. And that's with the oral form. And then it's important to note there's also a once a month injectable form that you would have to get from a brick and mortar doctor nurse visit. That is a brand name Vivitrol. But there you get a large dose of naltrexone in an injection. And then it's probably more likely you have the kind of initial fluey, headachy feeling for a day or two. We know from that medication, which stays in your body for an entire like 4 to 5 weeks, and there's no going back once you have the injection, people largely get over these same sensations and side effects within a couple days. So by week 2, if I've started people on the injectable or the oral form, they generally are not having as many or many severe side effects. That's the basics. It's really not worse than that. It doesn't give you allergic reactions. It tends not to cause like drug rashes. It doesn't interact with other allergic processes like asthma, dermatitis, psoriasis. It doesn't give you dementia, heart disease, doesn't increase or decrease your blood pressure, and doesn't really impact your cognition, your energy, your mood. It's really not really psychoactive. Some people do wonder, though, because it's suppressing kind of the opiate system, and we do have naturally endorphins, and we kind of have an opiate system because it helps us kind of regulate our day-to-day and help us kind of process environmental kind of experiences and what we like and what we don't like. Some of that is kind of based on our natural inborn opiate system. It turns out, though, if I block that pharmacologically with naltrexone, you're not suddenly depressed. You don't suddenly hate food. You don't suddenly not want to play tennis with your friend who you like to play tennis with every week. So you can still kind of enjoy sleep, sex, socializing, a poker game, blah, 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 whatever you kind of like to do that is not really kind of like craving and more kind of compulsive, obsessive behavior like drinking all the time or overeating. And it's also been studied for gambling disorders, methamphetamine disorders. It might help people smoke a little bit less, although it's not labeled as a smoking cessation treatment. Naltrexone seems to kind of suppress this kind of compulsive but not so good for me behaviors, including drinking. But we don't see the reverse side effect where it just like makes me kind of unable to experience pleasure or enjoy everyday life.
I would submit 50% of our listeners right now are probably going or thinking, yes, there's a pill that I can take that will make me ambivalent to alcohol. I've been really struggling. with alcohol, and awesome. I can go in and I can get a prescription, I can take a pill, and I'm good as gold. And then I would suggest there's probably the other half of the listeners who are like, oh my God, here we go again. Another doctor prescribing a pill. For goodness sake, can we please get away from this whole, like, just writing a script, take this pill, you'll be fine, and move into some holistic approaches. So I'm going to invite you to maybe make a case for both of those sides. Like, what would be the case that you would make for, no, naltrexone is fine and is good. Here's why it's beneficial. And then maybe just if you can make a case just as an example of why you would not do that and why you would encourage someone not to take that drug and actually take what I'm describing as a holistic approach.
Yeah. I mean, I totally acknowledge that you may have your own experiences with modern healthcare, with pharmaceutical products, with the whole, like, just finding a doctor you like first, you don't feel kind of listens or respects you, and then dealing with medications and pharmacies and side effects. Like, there's no end to reasons that we'd all like to avoid that, and nobody wants to be on kind of a medication if they don't have to, as a kind of general principle, and for kind of as little time as possible as a general principle. And yet most of us at some point in our life are going to consider, pharmaceutical treatment for some common condition. So if you're strictly kind of anti any type of prescription, this probably, you wouldn't see this much different than any other kind of like antidepressants for depression. Or would you take Zyrtec for your hay fever? Or do you want to look for kind of non-pharmacologic approaches to managing your sniffles? Some of us are fine with Zyrtec, and some of us don't want to put that in our bodies and would look for other stuff. So depending on how you land on that, then I'd have more of a discussion. But I think for people that are like, oh, great, there's a pill. For some people, that really is a powerful and maybe enough. We certainly see that in like opiate use disorder treatment, and sometimes in smoking cessation, where I've tried kind of stuff that hasn't worked for me. I'm still smoking, and then getting a prescription on something like Chantix really made a big difference. Or in the case of opiate use disorder, being on Suboxone or methadone has finally helped me not continue using heroin, where I was really having an astounding problem just trying to detox and then stay kind of sober. With alcohol, you could probably have similar kind of experiences where I've tried this, I've tried that. So I think it would be like, if you've been doing stuff that hasn't worked to your satisfaction, you haven't tried medication, it's an option, and that might be a good one for you. And you really just have to see how it goes. So I'm not kind of like getting people out of the work that it takes to make change, because alcohol is still going to be all around you. You're still going to have to make kind of conscious choices to do different stuff and not use it versus use it. But the medication can just make those easier decisions and make it less of a kind of internal struggle. I personally don't see anything wrong with that if the medication is otherwise affordable, accessible, and has an acceptable side effect profile in terms of safety. But for the person that really wants to go more holistic, I would say that's great too. And this is not going to be a guaranteed success story, and it's not necessarily something you have to start with. So kind of like to bring everyone to the same like pamphlet, like if you're ever interested in it, it's something to try. And then if you just want to go, well, okay, you're the alcohol czar of the country, and we have a crisis, and you have to get as many people to stop drinking in the next year as possible. If you had to really kind of rank order what interventions are going to work for an entire population, medication and naltrexone ranks pretty high. You can debate like what the top approach is versus the second, but in terms of like the top 3 or 4 things to do or to offer to everyone, there's no question from kind of years of data, and I think like the best designed studies, that naltrexone in a pretty simple medical management format, like you could get from a general practitioner, what you can get online, what you could get from a basic wellness kind of visit, plus addressing your alcohol, that works pretty well versus more intensive stuff that's like classic licensed alcohol treatment where you're going to go to a program, you're going to go a lot, you're going to have a lot of therapy groups and kind of like visits per week in terms of 12-step encouragement. How does it compare to just doing AA versus just doing medications? We think both of those are pretty good approaches, but the medications might be a little bit more effective kind of head to head. So then you can get into like how to build a national guideline and what should we recommend to everybody just based on the evidence we have. There you can say naltrexone and medication treatments actually stack up quite well. And they are kind of at the top of most of the guidelines you'll see.
I want to share the story of a former client of ours who came to us a couple of years ago, and he was drinking excessively. And he came to our coaching program, which is called Project 90, and we help people to stop drinking for at least 90 days. We do it without medication, or rather we don't encourage medication. We just do it as a holistic way, and we do it as a rewiring of the mindset. And this particular client came to us and he was on 4 different types of medications: acid reflux medication, blood pressure medication, sleep medication, and antidepressants. And he had been on those for what he said up to 10 years. So some of them he'd been on for a decade, some of them maybe a few years, etc. But certainly when he came to us, he was on 4 different medications. He then stopped drinking through our, let's call it, mind rewiring process. And then over the course of, I think it was 6 or 7 months, if I recall correctly, he got off all medication completely and is now, a couple of years later, sharing with everyone and anyone that he feels amazing. He's lost weight. He hasn't been on any medication for, since he got off it. His life feels there's so much more joy. He's sleeping well. He's not depressed anymore. He has very low stress and anxiety where once he had high stress and anxiety. So I guess my question is, what are your thoughts on that? Like, can you attribute just stopping alcohol to him getting off those 4 medications? First of all, I just want to ask you, what's your thoughts on that?
It sounds great. That could be really motivating to people that are finding it hard to focus on this like absolute recovery goal and focus more on alcohol. Of course, excessive alcohol use is linked to higher risk of higher blood pressure, acid reflux, poor sleep, and mood symptoms like depression, anxiety. So it could be all those were people treating symptoms of alcohol, but not really addressing the alcohol. So it's probably quite common that people that are heavy drinkers on a daily or regular basis have side effects. They have kind of medical conditions related to that heavy alcohol use. And then that's what your average doctor does. And I want to also fully acknowledge that the physician and medical workforce often ignores, misses, is incapable of, doesn't have time for, whatever it is, they don't recognize or adequately treat a primary alcohol use disorder. And that is very common in primary care. So while I'm saying, we can do all this stuff in primary care, we can also just completely miss the main headline, which is that Mr. B has, a pretty serious alcohol problem, and not much else is going to get a lot better without addressing that alcohol problem. So then the person, through whatever means, but it sounds like not using medication and using, this kind of behavioral approach, the holistic package, is able to make changes, which is awesome. And then they don't they start to lose some of those medical problems associated with the daily drinking. They feel a lot better. Their weight's going down. Their blood pressure's improving. They don't have the reflux, and they can sleep a lot better. They feel better, energy and mood-wise, concentration, diet, sexual function, all that stuff. That's like a huge win. Now, you could have used naltrexone in there to help you with that, but that person didn't, and they did great with the recovery plan that worked for them. So that does not surprise me, in that we more and more recognize all these medical problems that link back to alcohol. There was a lot of press this week about kind of yet another kind of article, study, and report pointing towards elevated cancer risk, especially in younger and middle-aged adults. linked to heavy drinking. So the kind of understanding that heavy alcohol use has profound kind of pro-cancer properties, and that's been under-recognized until like kind of the last like 5 to 10 years. And probably no amount of alcohol is like healthy in the way that people have also kind of grown up hearing about like red wine or the Mediterranean diet. We probably think that some alcohol is maybe neutral, like it's not going to necessarily kill you or shorten your lifespan, but don't call it healthy. So I like that case, that story, and that it shows a lot of stuff that can be linked to alcohol, and if the alcohol is addressed, the overall kind of health status can improve considerably and get you off a lot of medications.
Yeah, I mean, when you were putting forward the idea that if he had used Naltrexone, he would have been on 5 different medications, right? He'd be on the acid reflux, the blood pressure, the sleep medication, the antidepressants, and now he comes and he says, "Oh, and I'm drinking a lot." That would mean that a primary caregiver, like a GP or a doctor, would then put him on Naltrexone. Now he's on five medications. Is the way I see it, where I'm hearing it, that's a problem. Yeah, that's a big problem. And by your own, and again, I don't want this to come across as I'm criticizing you just because you're a doctor, right? It's easy to just throw all doctors under the bus. But a couple of things you said felt alarming to me, because you actually said in primary care, most doctors ignore, miss, or don't have time to primarily treat AUD or identify that an alcohol use disorder is the problem, because someone's coming saying, "I've got acid reflux, I've got high blood pressure, I've got sleep problems, I'm depressed." Why? I guess my question is, why the heck aren't primary doctors asking about their alcohol use and just saying stop, and instead saying stop drinking alcohol, and I don't have to prescribe you 4 different medications? Why is that not happening?
It probably a legacy of many decades of kind of ignoring it, not really accepting that we should be screening for it in the ways that we know we should be, and just kind of a lack of training. We are trying to fix that. The good news is, the doctor that graduated med school this year is much more likely to have been trained to think about alcohol, smoking, opiate, other substance use disorders, and then to do something about it, and to do something about it themselves rather just refer out to treatment. So it could be hit or miss, but I'm saying like that's not an unusual story where I've been seeing my doctor. He keeps like, if I go in and say, "Oh, doc, I'm anxious," but I don't like come in and say, "I need your help, not drinking as much." The doctor will say, "Oh, anxiety, here's some Lexapro." And that'll be the extent of, kind of the investigation. And that doctor won't put it all together. So I'm not, I don't know who that person was seeing for their medical team, but chances are collectively they were missing it, or the patient never felt comfortable disclosing or really kind of being real, because they felt they'd be judged, they were ashamed, they were guilty, or they just were never asked. Those are all like possible combinations of where this goes south and why alcohol use disorders are undertreated. And net, while I say it's all getting better, like we don't use enough of any type of effective alcohol treatment, be it behavioral, self-help, or medications, because we just don't recognize and kind of intervene on enough alcohol use disorder cases. But I can take it as a doctor. I was saying with Naltrexone, you might say, well, we need to start an alcohol treatment episode. I think a lot of your problems stem from this alcohol. We've got to get that under control. Like, I don't see any of these other things getting much better. And you're probably just going to feel, down and depressed and anxious and unable to sleep if you're drinking this much. Naltrexone can help with that. And then over the course of the same period of time, you might find you can keep Naltrexone going and start to take away some of those other medications. I think doctors also recognize more and more that polypharmacy is not great. Like the more meds you add on to the person's list, the fewer they take as prescribed, because none of us can really keep up with like proper adherence. The more side effects you get, the more drug-drug interactions you get, and the less sense you can make of anything over time. And especially as people get older, they're more likely to have 7 medications for this, for that, and blah, blah, blah. And we know that like that is also a problem. So polypharmacy as we age and for multiple chronic problems is not good either. I totally agree with you.
So beware of doctors over the age of 40 who are set in their ways and haven't been getting the most recent education, Dr. Lee. Is that kind of what you're saying? Is that the bumper sticker? Beware of doctors over the age of 40.
I think there's probably some truth to that. Yeah, I'm not saying don't go to your doctor who happens to be 50. That's how old I am. So, but look how great a doctor I am. So you can be at least as old as me, but no older. No, it's something like that. But it has evolved. Our kind of understanding is addiction as something we can do something about in most general care settings, be it a mental health clinic, a private psychiatrist, an emergency room, me in primary care. We now see that as a place to do a lot for these common substance use problems, including alcohol. But that is still a fairly recent paradigm. And that was not kind of how I grew up being taught in med school, and I kind of learned it early in practice.
Are you now open to those new ideas that are coming in? I mean, obviously you are, because you're talking about it and you're verbalizing that. But is that now the norm? Like if someone's going through med school, are they now open to the more holistic approaches? Are they now understanding alcohol use disorder and how that could down the line prevent a patient from having to take acid reflux medication, blood pressure medication, sleep medication, antidepressants? So what is happening? Like what is happening in the training of our young doctors now?
Yeah. There's probably more exposure to complementary alternative medicines and nutritional exercise, meditation, mindfulness, other types of wellness. Maybe it dovetails in some places with hallucinogens, which are a very kind of like hot area in psychiatry for different disorders. But kind of leaving the standard Western biomedical model and accepting that there's a lot of other stuff that people do throughout the world, throughout history, and that are not just kind of doctor, pharmacy, and kind of treatment plan. I would not say medical schools in the United States are great at teaching complementary and alternative medicine and making every physician graduate, a competent practitioner. But there is kind of recognition more and more that complementary approaches can be helpful and may be just as effective for common problems like sleep disorders, sometimes weight loss, back pain, and other kind of musculoskeletal and pain syndromes. So there's all sorts of, I think, kind of approaches we should be open to. And I think more and more medical schools are able to acknowledge that people can get help from a lot of different providers and sources and treatment paradigms. I think we get a little testy if it's like, okay, but you have something I know I have a good treatment for, and you're kind of refusing it because you have some opposition to Western medicine in general, that maybe you get less sympathy from the medical school dean. Like, if you have colon cancer, there's a pretty standard approach to it. And if you want to do alternative medicine for something that, we know could be curative, then I think doctors still kind of resent alternative approaches in some of those scenarios. But I think in general, I don't know, the way I was trained, not so much in my medical school, but then in my residency and in my kind of career where I am now at NYU, I was pretty open to a lot of different approaches to behavioral problems, to chronic medical problems, especially to pain and kind of psychosomatic issues where we just don't have great treatments. That's the other thing. Like if I had an easy curative thing, then I tell you about it. But in a lot of cases, people are spending a lot of time with physicians, but the physician doesn't have a great answer to some of these chronic complaints. And there you really have to be open to exploring alternative approaches.
Just a couple final questions, Dr. Lee, and thanks so much for spending time with us here. One of the anti-drinking supplements I've seen on the market is niacin, and you can buy that on Amazon. Are you aware, or could you just explain to our listener the pros and cons of taking niacin as a stop drinking supplement?
Yeah, I'm not that familiar with its effects, if any, on drinking. Niacin itself is like a B vitamin. It can cause some kind of like flushing. If you take it as a supplement, it's kind of famous for some like side effects, and a flushing reaction is one. And but it is it is part of like fortified grains. Like when my kid eats bread at school, they're probably getting some extra niacin because it's been seen as kind of a heart healthy B vitamin. I really don't know about what you're bringing up here, though, the effects on drinking, using it as a supplement. I'm all ears, but I don't know any like studies or analysis.
Yeah, it causes you to flush, like, that flushing feeling, like you said. And the idea is that you take niacin, and again, you're ambivalent to drinking. You don't want to drink. Yeah. Final question I wanted to ask you. I'm not sure I can articulate it succinctly, but I'll give it a shot. So you said you're 50, is that right?
Yes, I am.
Okay, wonderful. I'm 49, so you're 50.
All right.
So as time has gone on and you've been practicing medicine, and now you seemingly are very much open-minded to holistic ways as well as traditional ways, Western, Eastern, etc. Has your view on medicine and has your view on, say, big pharma changed over the years? Has it changed? Are you more like very strict, like, yeah, traditional Western medicine is the way to go? Or are you less positive about that now and more open to holistic or Eastern medicines? Like how is your mindset around? Let me give you a little bit more context before I give you an opportunity to answer. I know this is a long-winded question, but there is certainly a feeling amongst many of my friends who are very holistic based that the American healthcare system in particular just wants us sick enough because there's so much money in it and it keeps the system going. They want us to pop a pill. And doctors are influenced by big pharma trying to get them to give a pill to a patient when they walk in. And they're not spending the time digging in going, oh, this person has an alcohol use disorder, let's have them stop drinking. Instead, they're wanting to just write a script because it's good for business, right? So that's certainly the feeling amongst a lot of my friends and colleagues who are very health conscious. I'm not saying they're right, or I'm not saying they're wrong. I'm not saying my view is right or wrong. I'm just saying that tends to be the view of those who I spend time with. What is your view, having spent, I'm assuming, 30 years in the medical practice? Are those views warranted? Are they not?
I think there's some truth to all that. And yet you still have medications that you're better off taking than not, just like because they, I believe in science. Let me say that. And, I believe the COVID vaccine works. I believe like the polio vaccine works. And I think there's justification that's objective and not conflicted and not based on commercial interests in vaccinating everybody for this, that, and the other. And that's an area that's, been heavily challenged over the last couple decades. Childhood vaccines right up to who should get a COVID vaccine. But, if you want polio, don't take the polio vaccine. And we're seeing outbreaks in parts of the world rather, where polio vaccine efforts have broken down. There's just like, science has led to advancements and deeper understanding, and that includes medical science. And part of that is then inventing medical cures that can really work and prolong people's life expectancy and increase their quality of life. Now, that doesn't mean you can't have a long, healthy life without modern Western medicine. And certainly you can talk about whether we should be spending all this time and effort on intensive end-of-life care or prescribing 9 different medicines to everybody above the age of 65 versus working on healthier communities, better food chain in terms of healthy food, more opportunities for exercise, less dependence on screens and kind of sedentary entertainment hours. All that is like, kind of the modern capitalist country is not necessarily a healthy country. And the medical establishment is kind of like part of that, but it's not the overall whole problem. So something like that. I don't get paid more as a primary care doctor to write 5 prescriptions versus 2 prescriptions. There are certainly instances where doctors are directly incentivized to write more prescriptions by a particular pharmaceutical company. That, for the most part, those relationships are forbidden or are kind of stamped out pretty vigorously at the kind of place that I practice. But I would also acknowledge that there are kind of perverse incentives all over medicine, and people do what they get paid to do. I'm paid to see patients, so I'm going to see a lot of patients, but I'm not going to see more than I can handle, and I'm going to see enough so that I can keep my job. Surgeons generally are paid to do surgeries, so you kind of get what you pay for throughout medicine. But I think it's generally rare that people are incentivized to like prescribe more drugs just to get people on more drugs or to keep them kind of sick. Like I don't think anyone is consciously offering treatments with this kind of nefarious, sinister motivation to keep people unwell or to not help them. Generally, the people I practice with are trying to help their patients, and then let's look at the data. There's many conditions where we don't have great treatments, but there's a lot of conditions where we do, and those came straight out of the science factory, and they're offered to you by people you don't really like, but they're wearing a white coat, and they're called doctors. So again, like the colon cancer, we have very kind of well worked out kind of hierarchies of evidence about what works for a lot of different problems, and you can avoid that if you have that condition, but chances are you won't do as well in terms of your outcomes if you totally avoid, what we think is going to work. So, I find like the new obesity drugs fascinating. I don't prescribe a lot of that, but those are really taking over the GLP-1 analogs, and they're helping a lot of people lose weight and keep weight off and control their diabetes a lot better. And they're extremely expensive, and they're kind of blowing up the budgets of everybody's kind of like pharmacy benefit package. So should we pay for them? Should this many people be getting on Ozempic and Wegovy and the like? If I were overweight and struggling with diabetes, like I would want to be on them, but it's not going to be for everyone. But that's a new form of medication we didn't really have. They're branded products. They're incredibly expensive. They're making these companies trillions of dollars, probably when it's all said and done. But they might like really be improving the overall kind of population's health, and they might have done it through kind of a scientific discovery approach that seems to be working. So let's have that debate. Like, should anybody go on Ozempic? Because you can't just say, oh, you got to do everything else to lose weight, because generally people can't find a way to lose weight once they have a serious kind of weight problem. It's just really hard, and we don't have like great solutions. And this one all of a sudden seems like a big winner.
I'm all for prevention rather than cure. I'm sure that you would probably be that way inclined as well, Dr.
Yeah,
Lee.
it's nice, except that most people over the age of 50 are overweight. So like you don't, that opportunity for prevention is gone when you're seeing someone that already has the problem, right? Like I totally agree with prevention, but let's talk about people that are currently, with chronic diseases linked to overweight. And then what are we going to do, for that person?
Well, Dr. Lee, I could talk to you for another hour or so. I'd love to ask you more questions, but we're out of time. So I want to just thank you very much for making the time and for answering my questions. Thank you for what you do. I know that you're very passionate about helping people get over alcohol and opioid use disorders. And I know you've done a lot of clinical trials and treated many patients struggling with addiction. So thank you for that, and I acknowledge you for that. Where can our listener find more about you and your work online if they so desire?
Yeah, the Or Health story, which is kind of Naltrexone for alcohol through an app, and that's the company where I'm a science advisor. That's Or Health, OAR health.com. And then my own faculty page, just Google Joshua Lee, NYU School of Medicine, and you'll find all my stuff on our school's website.
Amazing. Dr. Lee, thank you so much for sharing your time with us today.
Thanks so much for having me.